I've been asked to give you a talk about the use of 3D in gynaecology ultrasound so that you can see what I do with 3D. These are all the different areas within gynaecology that I have used 3D on, and I will show you examples of all of these. It's most useful probably for the diagnosis of congenital uterine anomalies. You should, when you're doing a scan, always look at the uterine shape, because a congenitally abnormal uterus can be associated with subfertility, miscarriage and premature deliveries. When we look at the shape, we look at it in 2D to start with. And so on this side, you've got a longitudinal view of the uterus with the cervix here. I always scan in this same way. So I've got the patient's head here, I've got her feet here, and the bed on which she's lying here. So bladder is always here in my longitudinal views. So there's the cervix here, cervical canal into endometrial cavity. This is the anterior wall, fundus, posterior wall, and back to cervix. This is the longitudinal view you get, and then in the transverse view, I've got right on this side and left on that side. And when you're doing your scans, I know I'm talking to the converted, but you always need to do that systematic scan in the longitudinal plane from one cornu to the other, and then rotate your probe to the transverse and go from cervix to fundus and just drop off the top, and the other way around, doesn't matter. But be very sure always to look at the transverse view to look to see what does the endometrial cavity do at the fundus. The problem is that when you are in the transverse plane, you can't really tell when the endometrial cavity separates into two, whether that's because the uterus is arcuate, subseptate or septate. And it's because you can't see the uterine fundus in a 2D view in most cases. And you need to be able to get the coronal view. And the coronal view is the purple line here that separates the body into an anterior half and a posterior half. And that allows you to see the coronal plane of the uterus and work out what kind of shape this uterus is. It's nice if the patient is in the luteal phase, because then you get a really good contrast between the endometrium and the myometrium, because the endometrium will be bright white and the myometrium darker. So you get a nice contrast. And then it has to be transvaginally and or transrectally if transvaginal is not possible. You would do your systematic planes and then take a 3D view and then play around with it. On transabdominal ultrasound, but also transvaginal, if you have a retroverted or an axial uterus, you can sometimes get that 3D plane because of the way that the ultrasound waves are not bounced off the fundus, but using 3D is much better. I use this classification from 2003 from Salim and Jurkovic. I think it's the best classification. It's the most reproducible, and I like it very much. And if you tell your colleagues this is what you're using, they will always know how to interpret your ultrasound. These are the different classifications, and we're going to go through them one at a time. The range of abnormalities goes from normal to arcuate, subseptate, septate, bicornuate, didelphus and unicornuate, with or without a communicating horn, which may or may not be communicating, the rudimentary horn. So a normal uterine shape has got a convex outer myometrial contour. So this is the coronal view, and it's just a diagram to show you the details. Convex outer myometrial contour, but you're allowed a 10 millimeter dip in there. If you have a 10 millimeter dip, it is still considered convex. The inner myometrial contour is flat, and you end up therefore with a triangular endometrial cavity. There are two interstitial portions of the fallopian tube, one on that side and one on that side. That was a normal uterus. In an arcuate uterus, you get a little dip here at the fundus, and that makes, this has to be an angle of more than 90 degrees. So still you have a convex outer contour, but a slightly indented inner endometrial contour, and that angle is more than 90 degrees. So the yellow angle you can see is 90 degrees, and if it's more than 90, that's an arcuate uterus. You still have a triangular cavity, you still have two interstitial portions of the fallopian tube. In a subseptate uterus, you can see that the little dip that was made it arcuate is now deeper and sharper, and it's now less than 90 degrees, and it's a subseptate uterus. So still a convex outer contour, an indented inner contour. With that angle you can see is now less than 90 degrees, and I usually have a piece of paper if I'm not sure, and I hold up the corner like that, and you immediately see if it's more than or less than 90 degrees. The septum does not extend to the cervix. That makes it subseptate as opposed to septate. And there are two cavities at the top, one there, one there. Two interstitial portions of the fallopian tube, and that is different to a septate uterus. And here you can see that this septum reaches all the way down to the cervix. Otherwise it looks similar. Convex outer contour, an indented inner myometrial contour with an angle. This angle is less than 90 degrees. The septum extending to the cervix, and two endometrial cavities. Two interstitial portions of the fallopian tube, exactly like before. You can see how that's different to a bicornuate uterus. In a bicornuate uterus, you've got a dip here of more than 90 degrees. You can measure it in the coronal plane by looking for the interstitial portion of the fallopian tube, and you draw a line between those two, and then you drop down to just to the top there, and if that's more than 10 millimeters, then that is one of these. Two cavities, two fallopian tubes, and that makes it different from a didelphous uterus, or where you have two uterine bodies really essentially entirely separate. And they are often in different planes. Rather than them both being in this plane, it's a bit like bunny ears. You often have one going this way and one going that way, which makes it very hard to capture on 3D. Two cavities, two cervices. They might be in one body, but you've got one external os here and one external os there. And two portions of the fallopian tube. A unicornuate uterus is surprisingly common but quite easily missed, and in this you have a single uterine cavity which is described as banana shaped, one interstitial portion of the fallopian tube just there. And if you see a unicornuate uterus, you have to look for a rudimentary horn. If you don't look for it, you will miss it, and there may well be one. And the rudimentary horn will be near it, and it will have a little bit of endometrium in it, or a small endometrial cavity, or maybe even some blood. And you may or may not see a communication between this cavity and that one, which means it's either communicating or non-communicating. And a single cervix. But you can also have variations. You can have one or two cervical canals in one cervix, or you can have two entirely separate cervices. And with any of these, you can also have a septum. So you can have a longitudinal septum through the vagina, or you can have a transverse vaginal septum, and you need to look for those. And with any of these congenital uterine anomalies, a degree of obstruction is quite common. And of course, if it's more or less complete obstruction, you'd get blood in the vagina, or blood in the endometrial cavity, or blood in the tube, and I'll show you some examples. And it's always very important to arrange for a renal ultrasound in women who have a congenitally abnormal uterus, because they may well only have one kidney, or have some other horseshoe kidney, or have some other abnormality. So you need to know about that. So what does it actually look like on 3D? So here's an image of the cartoon on the right, and then the 3D image on the left. And you can see again, here you've got this nice convex outer contour. That's an interstitial portion of the fallopian tube, that's an interstitial portion, and you've got the cervix down here. This is the arcuate uterus, and I've drawn a line between the interstitial portions of the fallopian tube and drop down to work out that distance, but you can see that this angle is more than 90 degrees. This is a subseptate uterus, so again the fundal contour is flat, two cavities, one cervix, and I'm measuring the length of the septum, which is clinically relevant to gynecologists potentially considering surgery. This is a septate uterus. Here we've again got this convex outer contour. I've drawn a line between the interstitial portions and dropped it down. And you can see, in fact, that this dark line, the septum, separates the cervix into two as well. So this septum reaches all the way down to the cervix, and that's what makes it septate. And you can take a view just of the cervix. You don't have to take the entire uterus. You can take whatever you want. And sometimes it's very useful to just look at the cervix to get a better view. And here you can see that the septum goes all the way down. And if you were to put fluid in the vagina, which I haven't done, but you potentially then can see the beginnings of the vaginal septum as well. In the bicornuate uterus, you can just see the outer myometrial contour has this big dip in it, more than 10 millimeters, and then there are the two cavities in a single cervix. And this is the didelphys, and I told you it would be a terrible picture, which it is. This is the best I could ever do with the ones I've seen. The horns are in a different plane often, so you can't capture them in one coronal view. But here we've got the cervical body. There is one uterus and there is another one, and each of these uteri of course are unicornuate. They each only have one tube emerging from the edge. And on 2D, didelphys is easier to see than it is on 3D. When you're scanning in the longitudinal plane, you'll come across one horn, and when you go round the other side, hey, there's another one. And then what you do is you go back to the center to see where do they join. And so in this slide, you can see the right horn and the left horn. And then here you can see this is the right cavity going up into a cervical canal. This is the left cavity going up into the cervical canal. And this is the cervical body. I thought I'd show you a little video of a case, a young lady who came to the gynecology clinic. She'd been on the pill for a long time, but decided to come off 6 months previously. And all her life, she'd been absolutely, well, her adult life, she'd been plagued with vaginal discharge, and there was never a reason found for it. She'd come off the pill for 6 months and she'd had no periods, but she had severe cyclical pain and this ongoing horrible discharge. And this is a 2D longitudinal scan, and you can, what you've seen probably by now is there's a little hemorrhagic ovarian follicle cyst, so she has ovulated. You can see that there are two uterine bodies. Let's wait for one to come in with luteal phase endometrium. Again, evidence she has ovulated. There's one. There's that hemorrhagic follicle going out the other side. You can't get very good views of the cervix, and that's the only problem with this little video clip. One uterine body and another one, and there seems to be some fluid just at the top there. And when I rendered that on a 3D view, you've got one uterine body here, you've got one here, and you've got the endometrial cavity with this bright luteal phase endometrium. Can't see the cervix very well, so I rendered a separate view. And you can see here that there's a collection of old blood in the cervical canal. So she has a didelphys uterus, she's got cervical stenosis, and she's ovulating and menstruating, but it's not coming out properly. It's all collecting in her cervix, and that's the cause of her discharge. So we also had a scan done and realized she only had one kidney too. So suddenly she's come from being somebody with ongoing discharge and a bit of pelvic pain to knowing exactly why she's having all of those things. That's very useful. When you're scanning somebody, so important to look for a unicornuate uterus. They're so common and actually quite difficult to spot if you don't look for it. So this is the 2D view of a unicornuate uterus, but it looks completely normal, doesn't it? It's not until you go to the transverse view, and you can see it's transverse because I've marked it sideways, as it were, and this cavity is essentially circular, and no matter how high you go, it never becomes a longitudinal stripe, it stays circular. And when you then render that for 3D, that's what a unicornuate uterus looks like. So you can only ever find the single interstitial portion of the fallopian tube. This one didn't have an accessory rudimentary horn. And on hysteroscopy, when you pass a hysteroscope into the endometrial cavity, here you can see a single ostium, which is where the interstitial portion of the fallopian tubes comes into the uterus. There isn't one on the other side. As I said, when you found a unicornuate uterus, you need to look for, is there a rudimentary horn? And this is a transverse plane, and this one was on the left, so I'm looking in the other way, and I found a little nub in there, which could have been ovary, but it wasn't ovary, because the ovary was seen entirely separately. So tracking it back, there was some kind of communication, but it wasn't until we rendered that little nub in there on 3D, you can clearly see that there's some endometrium in the center of it. So that was it was a rudimentary horn that was connected but not communicating. And so when she menstruates in that horn, she'll have severe pain because really the blood's got nowhere to go. Just showing you those things. So the conclusion for uterine shape is that you need to look very carefully in 2D because you can spot most abnormalities, and after a while, once you've done a lot of 3D, you can predict what it's going to be from the 2D plane, but the 3D really helps you to learn what they look like. On 2D, does it separate into two portions, and if so, what's causing that, and can you find a second uterus? Luteal phase is very good, and you can get the coronal view and categorize the abnormality, and then tell your colleagues that you're using this classification system, not a different one. So that was the most useful, I think, reason for using 3D, but I use it a lot. So you can also use it in fibroids. And this paper came out in the White Journal, the International Society of Ultrasound and Obstetrics and Gynaecology, ISUOG, and their journal is called the White Journal. And this paper was in there to help you to describe fibroids that were all talking about the same classification system. This is an image, so it'll be familiar to all of you, I'm sure, that there's submucosal fibroids type 0, which are polyps essentially. These are submucosal in contact with the cavity. An intramural fibroid, these are subserosal fibroids. These are transmural, and this is then pedunculated subserosal. And for fibroids, it's a bit difficult to apply 3D because with fibroids you get so much shadowing, and therefore your 2D image often isn't very good, as we all know. But the 3D image is only ever as good as your 2D image. If the 2D is no good and you haven't spent time optimizing it, your 3D also isn't going to be very good. And by default with fibroids, that's very much the case. But I've chosen some examples where it was really useful to show you that actually when you're looking at a fibroid and you can't quite work it out, have a go at 3D because it might just give you the answer. So in this image here, it's a longitudinal view of the uterus. There is a fibroid, here is a bit of cavity, but exactly what's going on is a little bit harder to see. Whereas on 3D, it became really clear that that fibroid is deviating the entire cavity sideways. This is a separate case. I can see the endometrial cavity and I can see something within it. But again, exactly what the relationship between the fibroid and the endometrial cavity was is unclear. And it's very much something that gynecologists want to know. Not only where is the fibroid, how large is it, but how and to what extent does it alter the endometrial cavity. And here on 3D, you can quite easily see that this is the fibroid, this is the cavity, and look how it's indented by it. And you can work out what percentage, more than or less than 50%, is indenting the cavity. It's all useful information. In this case, this is an almost coronal view, if you like, of a submucosal fibroid and an endometrial polyp in the same case. And you can see that they look a little bit different. The endometrial polyp has got a bright ring of endometrial tissue on its outside, and you can only see them because there's some fluid all the way around, as you can see. So a little fibroid and a polyp. And fibroid polyps are quite nice to see on 3D as well. Again, in this example, there is something here in the endometrial cavity. This is anteverted uterus. You can see a little bit of vascularity, but what exactly is going on at this low level, not sure. And again, lovely coronal view. There's the fundus, this is the endometrial fundus, and there is this fibroid sitting quite low at a cervical level. And then when I turned when you do 3D, you get one plane, but you can turn it in any direction you like. And when I turned it sideways, I could see this is the stalk, and this fibroid polyp is sort of hanging down into the lower uterine cavity. Again, useful knowledge. You can say to your gynecologist, that's the thickness of the stalk and the length of it and where it's coming from, and at hysteroscopy it'll help them to assess whether it's resectable. Another case here, you can see something, but exactly what extent it's indenting is difficult to say, and you can see it very clearly here. And then one more case here, another fibroid polyp clearly seen in the endometrial cavity. So it's not the best reason for 3D, but it's nice. It gives you some additional information. Adenomyosis looks really nice on 3D. So in adenomyosis, you have invasion almost of the endometrial tissue into myometrium, and this is a little video of a woman with severe adenomyosis. It's a longitudinal view of a uterus, an anteverted uterus, and you can see in the center the endometrial cavity, and then anteriorly you can see blood in little cystic spaces, and you can see a lot of endometrial islands, little white splodges through the myometrium, and a lot of shadowing, like a rain in the forest, they say, or I think of it as Luxaflex blinds. But so what does that look like on 3D? Because here it's barn door easy, this is clearly adenomyosis, but sometimes it's more subtle, and the 3D looks similar, so it's nice to have a look at it on 3D. So this is what that lady looks like on 3D. Here is the triangular cavity, and you can see islands of endometrium in the myometrium. And if you can scroll through your plane as well as looking in any other different direction. And when you scroll through, here was a little island which was just a cyst now, where when she menstruated, she bleeds into that little area. It's unbelievably painful. This case was a slightly more unusual adenomyoma. So here is a transverse view of a uterus. Here is this thing. It looks like an adenomyoma, but it looks like a cystic area that she's bled into. The ovary is here, and if in the transverse plane you look to see where does that interstitial portion of the fallopian tube go, because you want to be sure that that's not an interstitial pregnancy. But it was clear from the interstitial portion, it wasn't ovary, it didn't look like a fibroid, and when I looked at it more clearly here, it just looks like an adenomyoma, but in a funny position. And this was in a young girl. She was 18 and had severe cyclical pain, really horrendous. But so young, 18, 19, something like that. And what in fact this is an ACUM. It's a new category of congenital Müllerian abnormality, but I didn't put it in that section. I think it fits better here. You can see that this is not a fibroid. This is a bit of myometrium, and it is lined by endometrium. And when people menstruate, they bleed into this very tightly confined space. And it's a duplication error. You have a little bit of a second uterus going on at the insertion of the round ligament, so away from the interstitial portion of the fallopian tube, and you get this little extra uterine body, if you like, and it's in young women. It's not an adenomyoma, it's lined by endometrial tissue, and these are very easy to peel off laparoscopically, but it's an important diagnosis to make. It used to be called a juvenile cystic adenoma, but it's now known, it's recognized as an ACUM. Women who have a congenitally abnormal uterus often have a degree of obstruction, as I said to you earlier. It may be at the point, if they have a subseptate uterus or a septate uterus, where the septum is close to the cervix, those spaces are often very tight, or it might be external cervical os, or it might be anywhere. So when they menstruate, they can have more retrograde menstruation than other people, and they seem to be more susceptible to adenomyosis and and endometriosis. And this is going to be one of these cases. This lady had a bulky uterus. You can just see the cavity there. In this 2D view, you can see these islands of endometrium. She's got little myometrial cysts. So she's got adenomyosis. In the 3D view, as I said, it becomes much more clear that this is adenomyosis. She's got a bit of cavity there, and she's got islands of endometrium there. And she had had a subseptate uterus, she'd had septal surgery, but she still had the adenomyosis. And when you see adeno, you must always look for endometriosis, actually hunt for it, because they may well have that as well. Looking at the cervix, sometimes the cervix looks really unusual, and this is an appearance I've seen a few times now in young women, where it looks like this. Otherwise there's nothing going on, pretty asymptomatic. It tends to be an incidental finding. And on 3D, that looks like this. There's that cervix, and this is just the arbor vitae of little endocervical glands secreting mucus. So this is a completely normal cervix, but it looks reassuringly normal on 3D. And then this lady came to the postmenopausal bleeding clinic. She was in her 60s, she was on HRT, and she'd had a tiny little bit of discharge, not properly bleeding, but she'd had some pelvic pain and was concerned. And when I did her ultrasound, this is the anteverted uterus, we could see blood here in the cervix. And of course, the first thing you have to think in somebody who's postmenopausal with bleeding and a funny cervix is that it's malignant. That would be your first thought. So I thought, let's have a look at that cervix a little bit more carefully. She was on HRT. I think it was one of the cyclical ones where you would expect some bleeding now and again. And she had this lesion. This is in the longitudinal plane. So this lesion isn't solid, it's blood. And this lesion at the bottom of it wasn't vascular. Now that doesn't mean it can't be tissue, because not all tissue looks vascular on ultrasound. But I was still not 100% sure what this was, until I did the 3D, and then it became more obvious, because in a longitudinal uterus, the coronal plane is displayed this way as though you're standing, and suddenly you get gravity. This is the cervix, it's filled with blood, and this was a blood clot. And it didn't wobble like jelly on a plate can wobble, like in a hemorrhagic ovarian cyst, but nonetheless, that's all this was. The cervix looked completely normal. She had a tight cervical stenosis, so when she had a little bit of bleeding on her HRT, it couldn't come out, separated out into clot, and it settled with gravity. So 3D helped me there. This was very sad. This was a young woman who presented at 9 weeks in pregnancy, passing grape-like clusters of tissue. So she thought she was miscarrying. Her previous smear had only been 4 years previously, and it had always been normal. She had had a little bit of bleeding in between periods, some intermenstrual bleeding, but had not sought any medical advice about this. So at 9 weeks of pregnancy, she came and we did an ultrasound, and the pregnancy was intrauterine and viable. And when we looked at the cervix, it looked quite heterogeneous, but not, you can't really see. So I always put colour on every cervix I scan, because it can really, really help you. And sure enough, there was very strong vascularity in this irregular area at the front. So I decided to do a 3D of that, and that is the rendered view of, that's the longitudinal transverse coronal plane, and this is the rendered view, and you can see how irregular and strongly vascular that is. And there's really nothing that's benign that will look like that on ultrasound. And indeed, she did have cervical cancer. She had sadly a termination and then a radical hysterectomy, and she did very well after that. Here's another, an older lady who had a Peutz-Jeghers syndrome, and she developed adenoma malignum and adenocarcinoma in the cervix here. Again, look at that vascularity in a otherwise bit irregular area in her cervix, but not that you go, oh wow. It was just a bit irregular, but with very strong vascularity. And she also had some pelvic pain. And this is just the rendered view of her cervix, this tumour in her cervix. But going up, rendering the view of her uterus, you can see this is a hematometra. So the cervix has become obstructed by the tumor, and she has bled up into the endometrial cavity and up and out into the fallopian tube. So a hematometra and a hematosalpinx, all caused by an obstructing cervical tumor. And then this lady came to clinic again with vaginal bleeding, and she had a big tumor there, but you can see it's quite regular, a regular smooth outline, and it's slightly hypoechoic, and it looks fairly bland. Putting colour on it, again, you can see it's clearly going to be malignant, and what this is a lymphoma. And on 3D, again, you can see how reasonably regular the outline is of this kind of cervical tumour compared to a squamous cell or an adeno. They look very much more ragged and invading than the lymphoma does. But lymphoma is quite rare in a cervix. Polyps can show up very nicely on 3D. So again, a longitudinal view. You can see cervical canal, lower endometrial cavity, and here the cavity is distended by something. It's got a feeder vessel. If you see on 2D a feeder vessel, it will be a polyp. You can't say if it's going to be benign or malignant, but if you see a feeder vessel, it will be a polyp. But if you can't see a feeder vessel, it might still be a polyp. So it's a bit complicated. And when I put the 3D on that, again, you select a box, you take your view, longitudinal, transverse, coronal, and then rendered. You need to squidge in your box, as you'll see, putting the green line in the center of your region of interest, and then when you do that, you come up with the rendered view, and here you can see the outer contour. This is the endometrial fundus, and there is an endometrial polyp, very bright and hyperechoic in the endometrial cavity. So again, it helped me that that area was a polyp rather than a global endometrial abnormality. When you see the endometrium's abnormal, it can be global or focal, and it helped me to work out that this was a focal abnormality. Little video for you. This lady was 53, and she was on tamoxifen, and she was having heavy periods. At hysteroscopy, they could see a large endometrial polyp, and it was resected. It was not malignant. And there was some benign secretory phase around it, and on 3D it looked like that. So the tamoxifen polyps really do look very nice on 2D and 3D. They tend to be larger and more obvious than the women who are not on tamoxifen, but also sadly, of course, they are more likely to be malignant, though it's been a very long time since I've seen a malignant polyp in somebody on tamoxifen. Most of the ones are benign. Coils. Coils look really pretty on 3D, as I hope to show you. So here is again an anteverted uterus, and you can see something very bright in the cavity, but you can also see 1, 2, 3 caesarean section scars. And it's really worthwhile when you're doing any scan to start looking for the scars. If you know somebody's had a section, there will be a scar. Go and look for it, because when you look for the scars, you can then also learn to judge if they're normal or not normal, and it's a good step toward diagnosing caesarean scar pregnancies. We'll show you some of those later. So this is a copper coil. You can see the turns of copper on the ring, and when you look at that in 3D, it looks like that. So you can judge the position of the coil very nicely and slightly more easily than you can on 2D. Of course, on a copper coil, if you turn the gain right down, you'll still see it. If you do that with a marina coil, you often won't. So you can tell it's a copper coil in another way. In this 2D image, this lady had come with pelvic pain, and they said, well, what position is this coil in? And you can see something here, but you can't, and you can see some shadowing there, but beyond that, it's really hard to know where is this coil. This is it in the transverse view. There is the upper cavity, again looks empty, and you can just see something there with some shadowing. Always look for shadowing. Although it's an artifact, it's really useful in lots of different aspects of ultrasound. And when I did the 3D, it's really obvious instantly where that coil is. You can see that one arm has perforated into the myometrium, the other one's in the cavity, but it's very low. The upper cavity is empty. So it explains the 2D image. You instantly get it. This lady came with missing coil threads, and in fact a missing coil. When I looked on ultrasound in the 2D plane, longitudinal, where is it? Coronal plane, where is it? I couldn't find it at all. So what I did was I thought, well, where's it likely to be? And it was an anteverted uterus. I thought if they've perforated, it'll probably be behind the uterus. So I set my region of interest behind the cervix. There's the cervix. I set it there, rendered that, and can you see the coil is just there? And one point will always be the same in all planes, so you can work out where you are, and the coil is just there. I don't know if you can see it. But she had a laparoscopy, and I said, it's behind the cervix, and it was exactly where it was. This girl came with pelvic pain, and she'd somehow managed to acquire 2 coils. So they had to be removed. Again, where is this coil? This is a retroverted uterus, and it doesn't seem to be in the cavity. Transverse view, there's something here and something there. But when you then put the 3D on, it's immediately obvious. This was a retroverted uterus, so the rendered image will be upside down. You've got cervix at the top and you've got fundus at the bottom. You can change that round, but I tend not to, in the same way that if you have a retroverted uterus, you don't flip your image. You should never do that, because then ups and downs are the wrong way round. So in a rendered 3D view, a retroverted uterus, the fundus will be here. So you can see this coil is upside down. This one's sideways. You can see it's an anteverted uterus. The fundus is here, and this one is in sideways. And this one, coil strings, you can often see the strings really clearly, and you have to be careful that what you're calling coil isn't threads. If you're saying, the coil's in the cervix, just be sure that that's not thread you're looking at. I mean, it could be in the cervix. But here, we could see something bright here, just to the internal os, and then an empty cavity, and, well, where is it? I rendered it really quick and easy. It's obvious, isn't it? This is the endometrial fundus. This coil is here and is perforated out, and it is sticking through the serosa. So it's perforated out backwards, and that's obviously done at the time of insertion. That doesn't happen afterwards. Well, how about this one? You can see an anteverted uterus, you can see cervical canal, endometrial canal, and what is this? And that's it in the transverse view. Really hard to make out on 2D, but when you do 3D, it's a Lippy's loop. And they're very old, these coils. You don't see many of them, but sometimes you still see somebody who's had their coil left in, or have been advised to leave it in, or it's become embedded, and you go, yes, okay. Other kinds of coils are Essure coils. They're not so popular anymore, but they were used briefly for sterilization purposes, and so you may still come across those when you're scanning. They're very small coils, metal coils, that sit in the interstitial portion of the fallopian tube, one on each side. And when they've been fitted, you'd be asked to comment on their position to prevent somebody needing a hysterosalpingogram to say whether they are in the correct location. They would generate fibrosis around them, and so you end up with an occluded fallopian tube on both sides. And in the longitudinal plane, you've been watching it play, of course, you're looking at the interstitial portions for these very bright linear echoes. Coming back the other way again, there's one, and then coming to the other cornu, and there's the other one. And this is in the transverse plane, coming up from cervix up to endometrial fundus, and you can, there's one and there's the other one. You can clearly see that there are little metal structures in the interstitial portions of the tubes. And on 3D, again, it looks ever so pretty, quite hard to get it neatly rotated round, but there's one coil there and one coil there. Endometrial cancer. When you're looking at a patient, particularly in a postmenopausal bleeding clinic context, for instance, what the endometrium looks like is terribly important. And you can tell a lot on 2D, which I want to illustrate with this example. This is a longitudinal view. This is a lady in her 70s with postmenopausal bleeding, not on HRT. So before she comes in the room, her risk of cancer is 1 in 10. So looking at the endometrial cavity here, you can see that it's clearly thickened. We use the sign guidelines to judge whether the thickness is normal or not, and not on HRT she's allowed 3 millimeters, and that's something like 10. When you then look at the transverse view, I find the transverse view is better for judging whether or not there's any invasion of the endometrial cancer into the myometrium. And you can see on this side, you've got a nice clear echo between the endometrial abnormality and the myometrium. But follow the line out here, and it does that, doesn't it? And that's exactly what this was. This was an endometrial cancer invading the myometrium. So you can learn a lot on 2D if you look for it. But I'll show you a little bit of what it looks like in other contexts as well. Here again is a retroverted uterus. So again, the bladder is up here, her head is here, her feet are here. And you can see strong vascularity in that thickened abnormal endometrium. And this is what it looked like actually on ultrasound. You can see that's a retroverted uterus, the cervix at the top, a distended endometrial cavity with irregular echoes in it, surrounded by some blood. Just coming back the other way, you can clearly see there's something in there. And when I rendered that, it looked like this. Again, it's upside down because it's retroverted. So the fundus is at the bottom, and you can see this very irregular polypoidal lesion with some blood in the center. The cervix is up there. This lady was older. She was in her 80s, and she came with postmenopausal bleeding with a ring pessary. So when people have a ring pessary for uterovaginal prolapse, if they then develop bleeding, it is often assumed that it's because of lower genital tract atrophy, that the ring is rubbing against the vagina and sets off some bleeding. And quite often that's exactly what it does. So she had a scan somewhere, and the comment was made on a vascular fibroid and a ring. And if somebody says to you vascular fibroid in a postmenopausal woman, you've got to really think, think, could it be malignant? Because it's more likely to be malignant. Older people sometimes do have fibroids, but you have to be careful when you make that diagnosis. So again, put colour on. That's not a vascular fibroid. That's never going to be benign. And that was a deeply invasive endometrial cancer, right through to the serosa. You can hunt round the edges and see, is there any normal myometrium? And on 3D, it was really obvious as well. So here at the top is the myometrial fundus. This is right side, left side. You can see that there is no triangular cavity left. It's all been replaced by tumour. Early pregnancy. Early pregnancy 3D can be super useful, and it's in these contexts I'm going to show you examples of all of these. Heterotopic pregnancy, where you have a pregnancy in more than one location at the same time. And this girl came to clinic with an ovarian cyst. She was in early pregnancy. At 6 weeks, she'd had severe pain suddenly, and she was admitted with query appendicitis. She was let go again after a few days, and then had developed this ovarian cyst. And so she came for a scan. And what I could see, this is her ovary. You can see there's a little bit of fluid within the ovary. You can see 1, 2 corpora lutea. Yeah, this is her ovary. Then looking at her uterus, toward the right side, on the same side as her corpora lutea, like any ectopic is often much more likely to be on the same side as the ovary with corpus luteum in it. There was an intrauterine pregnancy, but there's also this lesion just in an almost subserosal position, but it was exactly at the level of the interstitial portion of the fallopian tube, and this was it in the transverse view. So I took a 3D, and I realized and noticed, yes, that little nub in there seems to communicate with the uterus, and you can obviously see a viable intrauterine pregnancy just below it. So this is what it looked like on panning through in the longitudinal plane. So there's that little nubbin, there's the intrauterine pregnancy. It's panning through and then coming back out again toward the right. There is that little area, and then we're coming out back onto the right ovary with the 2 corpora lutea. And so I did the 3D, and if you do 3D and you add time, you've got 4D. So this is my very amateur attempt at 4D, where you just have to play around with the buttons and see what turns up. And what you can see is, you can see the intrauterine pregnancy, and there is the ectopic pregnancy. I'm sure she had an ectopic pregnancy as well as a viable intrauterine. She ruptured the ectopic, but the pain settled and she was never operated on, and the intrauterine pregnancy continued. So if you look, you'll find that she didn't have an ovarian cyst. They were two corpora lutea in the same ovary. Caesarean scar pregnancies are really important to diagnose. How many of you have heard of a caesarean scar pregnancy? Have you seen any? Have you diagnosed them? Excellent. This is one example of a scar pregnancy. In a scar pregnancy in somebody who's had a previous caesarean section, where if the caesarean scar doesn't heal properly, instead of nice thick myometrium, you end up with a niche, a gap. And if the next pregnancy settles in that niche, then the placenta, the trophoblast, will just hunt for oxygen and will become, or can become, deeply invasive. So scar pregnancies are the forerunner of placenta accreta spectrum, which means placenta accreta, placenta percreta, or placenta increta, any of those. And so there are very strict definitions to help you to diagnose whether a pregnancy is a caesarean scar pregnancy. And they are essentially that you have to have an empty cervical canal, an empty upper uterine cavity, and then a pregnancy settled in the niche of a scar with vascularity showing that it is adherent, that it isn't a miscarriage on the way out. And so this was a very low-lying pregnancy. You can see that by about 8 weeks, these pregnancies, even if they start in the scar, if they become intrauterine, will occupy the whole endometrial cavity by about 8 weeks. So it's very hard to diagnose late. You're much better looking at 6 weeks. So this is what it looked like on 2D, and you can see an almost bulging lower segment. Put the color on and you can see clearly this trophoblast is invading the myometrium deeply. And on 3D it looks like this. And the use of 3D for scars is that it can make it really clear to you somehow that the upper cavity is empty and that this pregnancy is embedded very low. She had an ERPC with a Sorotka suture on standby, not tied but inserted and on standby. They're modified Sorotkas, they're not real ones. And that all went very well. Interstitial pregnancies are great to see on 3D, as I'll show you. So this lady came in very early pregnancy, and it wasn't clear exactly where the pregnancy was. So the endometrial cavity looked empty. The cervical canal looked empty. If you see this white line, it's always the same. This white line is where the bladder attaches to the uterus. And if you look down from that, this is the level of the internal os. The internal os will be there. So the cervical canal is there, and the endometrial cavity starts there, going that way. So always look for that line. So you can see it's an empty cervix, absolutely nothing there. And then toward the right, so in the longitudinal plane, panning out toward the sides, toward the right was this mass, this slightly hypoechoic mass with a slightly central liquid portion and very strong vascularity. So you can say, well, yes, that looks like an interstitial pregnancy, but could it be a very high up intrauterine pregnancy? And when you put your 3D on, it's really obvious, isn't it? You've got the endometrial cavity here, you've got a little space between it and the pregnancy in the interstitial portion of the fallopian tube, and sometimes you can even see a tiny little line, which you can sometimes see on 2D, but on 3D it's just blindingly obvious. Here's another one. In the transverse plane, there's the pregnancy, there's the ovary, and look what that looked like on 3D. You can see how pretty it is, but also how useful. Cervical pregnancies are very rare, very rare. And here you can see an axial uterus, an empty cavity. You can see here, there's where the bladder adheres. This is the internal os, and the pregnancy was below that. And on 3D, so it's the other way around now, fundus here, this is where the pregnancy is. It was non-viable, but it was in the cervical canal. She had an ERPC and it was uneventful. Molar pregnancy is another thing, of course, you'll be seeing if you scan in the early pregnancy unit, and it looked a little bit heterogeneous, not so vascular, just vascular at the periphery, and that's what it looked like on 3D. Fallopian tubes. This lady was sent to me with unusual free fluid in her pelvis. And when you look at that, you think, well, yes, it could be. What is it? So again, an anteverted uterus, and then this fluid behind. And I put the 3D on, and it was immediately obvious what it is. It's a big hydrosalpinx. And if you have a chronic hydrosalpinx, you lose the cogwheel echogenicity at the periphery. You may lose your incomplete septation. You may just end up with a retort-shaped tube full of fluid, and on 3D it looks much more obvious. So making that a little bit more complicated again, this lady had had a Novashore endometrial ablation. So this is done in people who've got maybe menorrhagia. The endometrium is destroyed, and you end up with myometrial adhesions. But sometimes the entire endometrium is not destroyed. You get some regrowth, often near the fundus, and then menstruation can recommence. But if you have myometrial adhesions, the blood can't get out. So this woman did, in fact, have amenorrhea, but worsening cyclical pain. And the pain, it's a recognizable story. It can be very severe. She ended up, after the scan, she had a hysteroscopy, she had a big hematometer, they couldn't divide the adhesions. She ended up with a hysterectomy, but this is what her scan looked like prior. This is on 2D. You can see the cervix is up here. There is something in the endometrial cavity that's not vascular. Doesn't mean that it can't be tissue, but I'm thinking blood at this point. And then this is in 2D. This is her uterus, and this is an adnexal mass seen in a longitudinal plane and in a transverse plane. And I think you'd agree it's pretty hard to work out what's what there until I put the 3D on. And that's, again, you just put it on your region of interest, and you end up with different planes, and you can render it. And in the rendered view, it seemed to me much more obvious. So this was her uterus, there is the hematometer, and the blood is going up into her fallopian tube because she has dense myometrial adhesions below. So now she's menstruating again, the blood's got nowhere to go but up and out. And that's exactly what it was. She had a hematometer and a hematosalpinx, and it was all benign. So that was good to know. You can also use 3D in the evaluation of tubal patency. Now, I don't do this, but Dr. Exkustos does, and she has beautiful images where you need special software to contract away certain elements, and you end up with views like hers. Endometriosis is one of the things I'm particularly interested in, and in order to be able to spot deep infiltrating endometriosis, you have to know a little bit about what's normal and what's not normal, and what it looks like. This is a little view of normal bowel, and you can see it so clearly because there's a little bit of fluid in the pouch of Douglas. What you can see here is this white line is the serosa, then this dark line with a little white line in it is muscularis layer. Then you've got submucosa and mucosa to the center where you might have bowel contents. Then you've got submucosa and mucosa out the other way again, muscularis layer and serosa. If you have endometriosis that's affecting the bowel, the rectosigmoid usually, this is what it looks like. So you can see this was the normal muscularis layer. It's dark with a little white layer in between, and that is where the longitudinal and the circular fibers meet. So you get a little white line, a little interface. So you know that that is muscularis, muscle. And in endometriosis, you can see how that's become a big, thick, dark nodule. So that's what a nodule of bowel deep infiltrating endometriosis looks like. And when you render that on 3D, it looks very similar, but a bit prettier, if you like. That is the outer aspect of muscularis, which is always normal. It's always the area near the torus, near the back of the cervix, at the level of the internal os that's affected. If you don't look for it, you won't find it. It's as simple as that. So what you need to do is have your probe. We normally have the probe in the anterior fornix. If you pull it out a little bit and go backward a little bit and put it in the posterior fornix, you'll see bowel. And if you just do that, you will find these nodules if they're there. But if you don't do that, you're very unlikely to see them. This is me, this is the probe going into the posterior fornix. There's a little dark nodule in the center of the screen. What is it? So I'm scanning longitudinally from side to side, and then in a minute I'm going to turn my probe on that, and there it comes. And you can quite clearly see that's DIE, and you can see the posterior wall is normal, as it always is. On 3D, this is a different case. There's a nodule of DIE at the level of the torus. So this is cervix, internal os, and at the back of the internal os is where the uterosacral ligaments insert, and that's called the torus, and that's where you will always find, virtually always, your endometriosis. And occasionally on 3D, it looks like a windmill. And you can see that this tissue looks almost malignant. It looks like it infiltrates. You can see little tendrils go in different directions. Here's another example on 2D. Here's the ovary. Here's a lump of DIE, and there's a stent in the ureter, and you can see it can go no further. This was completely blocking the ureter. And on 3D, in fairness, it doesn't look very different. It's just nice to see what it looks like. So when you are looking at somebody with pelvic pain, or anybody for that matter, you should always judge the sliding sign, and it's ever so easy to do. All you do is you have your probe in the anterior fornix, and you very gently press your probe in and out. I never hurt people when I'm scanning. You have to encourage them to let their legs go nice and floppy, but then just very, very gently. And you can see that the bowel and the uterus move very smoothly against one another. So if they have that, they're very unlikely to have endometriosis. You have to look a little bit more carefully, but that's a great sign, a great starter. If you don't look for that, if you only do a systematic survey and measure stuff, but you don't look at mobility, you'll miss a lot of endometriosis. So it's important to look for a normal sliding sign in everybody. And then you can see how useful that is. So you can see in this case, the pelvis doesn't move at all, does it? Or you might see movement, but you'll see movement of the bowel and the uterus together, rather than bowel and uterus in different planes. So this pelvis is frozen. So then if we look a little bit more, in more detail, you can see there's all sorts of heterogeneity going on here. Looking at her in 2D, you can see the endometrial cavity. Well, exactly where is it? The endomyometrial junction is quite blurred. There are islands of endometrial tissue, white. There are little hemorrhagic islands. Something's frozen at the back there. This is the torus. So I said this is the bladder, this is the internal os, and at the back this is the torus, and that's always the center of endometriosis. So I thought, well, let's render that. Let's see what that would look like on 3D, and look. She actually has a subseptate uterus with endometriosis, with adenomyosis and endometriosis. Do you see? So you've gone from somebody who had a frozen pelvis to working out why has she got a frozen pelvis. She started off life with a subseptate uterus, must have been some obstruction, a degree of, and has now got really bad adeno and endometriosis. Ovary. This was a pregnant patient with an ovarian cyst, and of course we always worry terribly about could there be anything malignant in somebody who's pregnant. It's very rare, but again on 2D I couldn't really easily work out what this was, and on 3D it was blindingly obvious. It's a dermoid. So you've got lovely little fatty balls floating in sebum liquid. You can do more with ovaries. You can do the automated volume count or count follicles. I don't do that, but there's a software package for people who work in fertility units. The bladder, again, go look for stuff and see what it looks like on 3D, otherwise you'll never find out. This patient had had 1, 2, 3 TVTs fitted. Now that's really quite unusual. They might have 1 tape, but 3, really? And that's what it looked like on 3D. Just a bit of fun. And this lady continued to have dysuria. And she had a scan in the department and they said, well, there's something there in the bladder, but what is it? This is a transabdominal scan, right? There's the bladder, anteverted uterus, endometrial cavity, and something there was shadowing. And on TV, it looked like that. Again, what exactly is this? On 3D now, this is a 3D rendered view. It looks more like a coil, and just by playing around with the different planes, it looks like that. She had a cystoscopy and it looks exactly like the 3D views, doesn't it? It's a coil. At the time of insertion, they perforated through the anterior cervix into the bladder. So it sat there, and over the years it's become calcified, but also a nidus for infection. And so she kept getting UTIs. Of course, she wasn't exactly full of contraception either, but she didn't conceive. So that was at least a good thing. And then now and again with people with recurrent UTIs or incontinence or pelvic pain, if you look carefully from the moment you put your probe in, you look at the urethra, you look at the bladder, you look at the vagina, you look at the cervix. You don't just put it in and start looking, You just look very carefully as you insert the probe. And here you can see the urethra. The probe is pretty much on the perineum, urethra and bladder. And here is a diverticulum that's coming off the urethra. It's very wide-necked. Again, it's very useful information for the urologist. But this little diverticulum came off the bladder. This is somebody else, and it's very narrow, a small little bladder diverticulum. And cysts in the vagina, you can see those nicely too. This is it on 2D. We've got bladder at the front, got uterus in the middle, and then this thing at the back. And when I rendered that, it was much more clear. And the fact that it was not related to the urethra or to the bladder was nice to be able to see. And because you can turn the planes around, you can diagnose that. And other people, not me, image pelvic floor using 3D and look for prolapse. And what I did see though was a bowel fistula, and this lady had had a THBSO for fibroids and afterwards got an E. coli sepsis. She eventually recovered from that, and then she developed diverticular disease and had some bowel polyps removed at the same time. And it was after that that she started to pass feces vaginally. So she must have a fistula somewhere. And looking very, very carefully, and this is a rendered view, between her bowel and the vaginal vault, I was able to demonstrate a little connection on 3D. And just now and again, you see a tiny little bit of something in a vessel, just very rarely, and on 3D it was a little thrombus, tiny little clot. There was no reason for it, and we followed her up for a bit, and nobody was very interested, but it was a nice little clot. So I'm hoping that I've shown you that 3D has a lot of applications, that we have gone through this list, and that pretty much whatever you can see on 2D, you can take a nice 3D view of it, play around with the volume when the patient's not in the room usually, and see what the image can teach you about how you look at a 2D image and how it can help you make a good diagnosis. So I hope that I've shown you that there are lots of applications for 3D in gynecology, that I think it's most useful in the diagnosis of congenital uterine anomalies, cesarean scar pregnancy, interstitial pregnancy and coils, location and position. And that from my perspective, certainly 3D has taught me to see my 2D differently. So in a lot of cases now, I don't necessarily need the 3D because I know what it's going to look like because I've done it that many times. But it has really taught me how to look at the image in a completely different view. So I would say don't be intimidated by it. Just learn the basics from these guys and just make a start. And you will enjoy doing it.